Very good morning to one and all. We will be starting the first session. I invite Dr. Maskati, Dr. Elizabeth, and Dr. Leela Mohan on the dais. And the first speaker of the session is Dr. Lipika Rai. She is Senior Consultant in Pediatric Ophthalmology and Chief Medical Officer, Center for Vision and Eye Surgery in Chennai. And she will be speaking vision therapy softwares. Are they helpful? Dr. Lipika. And your time is 8 minutes, and you have to be adhere to the time strictly.
Thank you, everyone. Considering the time restraint, I would directly go on my topic, vision therapy softwares, are they helpful? We have been seeing, if we are doing these therapy softwares in our regular clinic practice, that so much is available, but it is so confusing which one to take and which not to do. So these are some of the abbreviations which has been used. The literature search which we have done while making this presentation, and these are some of the emerging technologies and what are the basic principles used in the technologies like dichoptic, perceptual, MFBF mode, etc. These are the emerging softwares. So there is so much available in the market that it is really confusing both for the doctors as well as what treatment to be given, and also for the patient, because most of the things are also available online. So you can, and these are the only things which I have taken which is available here with us. In India, it has been used most widely. Now, dichoptic therapy, it's not a new principle. It's a treatment modality which involves presenting a different visual stimuli to each eye independently in a way to encourage the use of amblyopic eye with simultaneous binocular function. This is important, and this has been used for a long time. And it is most useful with minimal strabismus or visual obstruction, and if there is an interocular difference in the acuity. And lots of softwares which has been making, or the apps which are coming, are based on this principle. Another thing, a little bit, I would say a little bit ahead on dichoptic is MFBF mode, which is nothing but monoocular fixation in binocular field. Here one eye sees detail and the other eye sees the background in the same space. The goal is the accurate perception of details with one eye and the perception of the background with the other eye. So these most monocular activities, it can be modified to MFBF mode. We just have to change the occluder to a filter and change the target so that it can be seen with the one eye. So the type of occlusion which have been used previously were like patches and all. This in the MFBF mode, it is a translucent light but less detail, and one eye can only see the background. You can either use red lenses, green, blue or cyan lenses depending upon the software or the technology being used. Now this is a paper where I just took this out just to show that how with the application of these two therapies, there are also the reports which are coming out that even with more than 20 years old, if there are 20 dichoptic therapy and BVT sessions are given with a minimum follow-up of 6 weeks, it is showing an improvement. But of course, they have also used the SVI integrator for the perceptual integration as well. So of 18 patients, 14 had unilateral amblyopia and demonstrated a median improvement of 2 logMAR lines. Obviously, the sample size is less, but that's how the reports are coming now with the different softwares. Now, effect of MFBF on amblyopia, there was a pilot study comparing it with patching, and it shows that the patching group did demonstrate 3 logMAR lines of visual improvement, but the MFBF group showed 5 logMAR lines at the end of the therapy. Now, binocular perceptual learning, it refers to any stable change in the perception of a subject as a result of the experience with one or more stimuli, and this is becoming more and more critical for more of the holistic approach in terms of the visual software's training. Now, how do perceptual learning-based amblyopia treatments differ from traditional? It is basically, fundamentally, it works on 3 different strategies: contrast, rebalancing, visual blur, and the partial presentation. The studies show promising in use of perceptual learning, including tasks like stereopsis, anti-suppression to enhance visual functions and stimulate the binocular system. Now, main types of visual perceptual therapies which have been used in the softwares on the apps are like some of the interactive video games. So there are different types of games which are being given to the kids. Virtual reality or augmented reality, which is pretty in nowadays. Video viewing, different softwares like Embleo Play. It is not being used that much because there are other things like QC, Binox are available. OccluTab, CureSight, all vision therapy related activities and softwares also combines perceptual learning. Now, what are the predictive factors for visual rehab after PL? Type of amblyopia, age, astig, baseline stereo, fixation stability, and contrast sensitivity. These things are very critical to determine how the patient would improve. So it is really important to document what all we are doing. Then this is beyond occlusion. This is perspective for amblyopia treatment using Orthoptech, where it basically evaluates magnocellular stimulator. And I think Dr. Santana Gopal would be here also who is the one who invented this. And it has been shown that this has also been helpful in treating the patients. And in one study which is done by himself and his team, it shows that patients were evaluated for improvement in visual acuity, stereopsis, BSV, as well as the amount of strabismus. All patients were followed up for 1 year with maintenance therapy, and none of them showed any regression. Before I move on to anything, I just forgot to mention that all these therapies, minimum time has to be at least 3 months. Because you have to give at least 20 to 25 sessions, 40 minutes to 1 hour each, before you can conclude anything, where am I going? And after that, the patient should be followed up. And for a year, they have to be seen for any regression or not. So ideally, it's like iGEM. I mean, that's what I say in my, just to the patients, because you cannot leave it. You have to keep on checking because the child is also growing and each parameter is changing. Now, this is another syntotic phototherapy. We don't have personally any experience in that, but there are some of the people who are using it, where they present the fovea with the different lights, and it stimulates the sympathetic and parasympathetic nervous system. While Orthoptech, it works on the parvocellular and the magnocellular pathway, and it has shown a positive change. Then we have Gabber patches, which is Revital Vision. Then virtual reality, which is coming up, the new things which all of us know is coming up. And obviously, I don't have the time to go more into it. Visual motor integration by using Sanet Vision Integrator. So this, again, it is a visual guidance of motor performance and offers primary programs used for vision training. And it's very useful for sports vision therapy for children who need a very high level of the training. And it includes eye-hand, saccadic, tachystome, and metronome training.
Kindly come to the conclusion slide.
Yeah, I am coming. Vision therapy softwares, we had put the things you can ask to me. So there is no one fit for all. We have to consider several factors before starting any therapy. If in doubt, first correct the basics. There are promising technologies coming which are more engaging and creative therapies. Cost and affordability is one thing, but there is no structured approach and consensus among usage of therapies. Thank you.
Thank you, Dr. Lipika. That was a nice overview of several therapies in the pipeline. I think only time will tell. We go on to our next speaker on neurovision therapy in amblyopia and its clinical significance. Dr. Damaris Magdalene is a senior consultant at Sri Shankar Deva Netralaya at Guwahati.
Good morning. I'm very happy to be here in your midst. I will be talking to you about Revital Vision, neurovision therapy in amblyopia, a clinical significance. I have no financial disclosure. As we all know, amblyopia is the leading cause for impaired vision in children and young adults, accounting for 232 million population. It is a cortical deficit that leads to reduced best-corrected vision in a healthy eye with binocular and stereoscopic dysfunction. Treated early during the critical period when the brain is plastic, considered untreatable after age 9. Can we improve amblyopia beyond the critical age? For this, we should know what is neural plasticity. It relates to the ability of the nervous system to adapt to change conditions in acquiring neural skills and retaining it. And there has been evidence for neural plasticity reported in case reports after prolonged patching or when the beta eye's vision has been lost or degraded by ARMD, cataract, and trauma. Large meta-analysis and RCTs have demonstrated limited vision improvement in amblyopes older than 11 years, even with permanent or prolonged patching. This is what is done in Lancet 2002 and also a PEDIG study which found that 25% improved with patching compared to 23% with optical correction alone. We used to do monocular occlusion, which leads to improved monocular vision but lacks effective anti-suppression therapy. But these days, amblyopia is considered as a binocular disorder, so there has been so many digital solutions for amblyopia. Do they really work? Dichoptic therapy, stimulating both sides of the visual cortex with equal stimulus, will improve stereopsis and binocular vision and hence treated binocularly. But still, there is no level 1 evidence to support the use of binocular treatment as a substitute for current therapies for amblyopia, including patching and optical treatment. On the basis of this review of the published literature, binocular therapy cannot be recommended as a replacement for standard amblyopia therapy. So these are the different digital solutions which are available in the market, and Revital Vision has got the FDA clearance and is effective for children above 9 years of age. So what is there in this Revital Vision? It is a vision training web app that effectively stimulates the brain visual cortex. It is tailored to the patient's specific need, algorithm-based cloud technology. It can be performed at home by the patient's computer, 30 minutes 3 times a week, 30 to 40 sessions in 2 to 3 months. And the outcome, there is improvement in contrast sensitivity, two lines improvement in vision, and also improvement in stereopsis. Exactly what is the mechanism of action? How does it work on the visual cortex? These are the 4 building blocks, that is the Gabor patch, neuronal lateral interactions, brain neural plasticity, and perceptual learning. Gabor patches are widely used in the field of visual neuroscience and has been shown to efficiently describe the shape of the receptive fields of neurons in the primary visual cortex. They represent the most effective stimulation, and this is what the software uses. The next is lateral interaction. To characterize an image, visual processing involves the cooperative activity of many neurons. So they have conducted experiments and they found the response to stimuli presented within the receptive field can be facilitated or suppressed by other stimuli falling outside the receptive field when present fail to activate the cell. So when it's only the target or with the target with the flankers and target plus flankers, they give the maximum response. And this is what they have used in this therapy. Neural plasticity, based on the evidence which we have already seen, where nervous system is able to adapt to change conditions in acquiring neural skills, new skills and retaining it. And perceptual learning technique, that is repetitive performance of controlled and specific visual task will enhance neuronal interactions and stimulate the specific neurons and effectively promote spatial interaction, improve the contrast sensitivity function, and hence the visual acuity improvement. This is how the stimulus is placed. Either they increase the contrast, the global orientation, or target displacement. So first there is 2 sessions which will identify the patient's cortical deficit, and accordingly the system generates the target to be given to the patient. For example, if it's a meridianal amblyopia, the system will understand that the patient is not responding to the stimulus at a specific degree, and accordingly they will give their visual stimulation. So the patient is given 2 tasks. The first display has 3 Gabor patches and the second has only 2. The patient has to identify which has the 3 displays, and accordingly he will press the right or the left mouse button. If there is a mistake, there is an auditory feedback and the patient knows that he is not doing well, and accordingly again the target is given to the patient. So we decided to evaluate the efficacy of revital vision in adult patients who have been used occlusion therapy with no improvement. 45 patients, and we found that the improvement was from 0.54 to 0.2 logmer units, almost 2.2 lines, which has been published. And now I have done a long-term results over a 5-year period of 89 patients. 25 patients, they remained the same, and all the others had visual improvement, either 1 line, 2 lines, 3 lines, or more than 3 lines, and they have been maintaining it all these 5 years. There is a broad clinical evidence with 26 clinical studies, 11 published in peer-reviewed scientific journals, 7 randomized control studies, and 5 ongoing RCTs. And also this therapy has been used in nystagmus, albinism, keratoplasty, Stargardt's, and keratoconus. To conclude, today the key to optimize visual functions lays in addressing the brain as well as the eyes, and that is revital vision neurovision therapy. Thank you.
Thank you. Any comments? Now I invite Dr. Quresh Muscati. He is consultant ophthalmologist from Bombay. He is past president of All India Ophthalmological Society and current president of SAOPOSA. He will be speaking on red light therapy for myopia control in children's new initiative. Sir.
Thank you, Dr. Subhash. And right at the outset, I have no personal experience with this, but I was fascinated by a talk I attended at the last APO conference. And I thought that I should just share it with you because we should know what is going on everywhere in the world. Tomorrow this might become mainstream. So we should know the pros and cons and what it's about. So this is based on the talk that I heard and the notes that I took down and then the literature search. So it's they call it RLRL, which stands for Repeated Low-Level Red Light Treatment for Myopia. Why does it fit into the previous 2 talks have been on amblyopia? Because the Chinese first tried it for amblyopia. And it worked for amblyopia. And they took ethical committee clearance to see whether they could use it for myopia control. So progressive myopia, we know, raises the risk of irreversible visual impairment. So prevention and control are crucial. We know that we should be spending more time outside to reduce myopia risk. In fact, some researchers said that if we can't take the children outside, let's make glass walls and glass ceilings so that more light will come in. However, this strategy is costly and challenging. We could also all sit in golf face and have our schooling there in the brilliant sun, but that is not very practical. So there was a landmark study by Jiang et al. They proposed delivering light directly to the retina for short bursts through a device that emits red light at a wavelength of 650 nanometers. So they did a multi-center trial. They tested this as a method of controlling myopia. The data showed that the treatment is effective, safe, and because it is at home use and just 10 minutes bursts twice a day, it's quite highly acceptable to the users. So what was the inclusion criteria they used? It was a single masked parallel group study. They enrolled myopic children aged 8 to 13 years, so little older kids so they could follow, with a spherical equivalent refraction between -1 and -5, anisometropia of less than 1.5 between the 2 eyes, and astigmatism of less than 2.5. So these were mild to moderate myopes, no severe astigmatism. They were randomly assigned to the intervention group, which is red light plus their single vision spectacles. I will call it SVS, or the control group, those wearing single vision spectacles only. Red light therapy was given at home, supervised by parents. A desktop device delivers the light, that's the device that you see, delivers the light at an illuminance of roughly 1600 lux and power of 0.29 milliwatts. So over a 12-month period, the treatment was given just twice daily, 5 days a week, Saturday, Sunday off. Each session lasted just 3 minutes. So main outcome measures were change in axial length and the SER from the baseline on each follow-up visit. The follow-up visits were at month 1, 3, 6, and 12. device is connected to the internet. Please understand, China is not a democracy. So they want to know exactly what the kid is up to, the high command. So the device is connected to the net. It requires the user to log into the system using a designated username and password so that the research coordinator at the back office can observe, document, and monitor the treatment and see how compliant the patient is. Did he do it for 2 minutes? Did he not do it today? The study further demonstrated that treatment efficacy increased significantly with improved treatment compliance. So what are some of the cons? Perhaps we could extend this. Why 3 minutes? It could be more, but they'd taken approval of ethics committee for 3 minutes, so they couldn't extend the time. But no evidence was there to suggest that further extension would not be suitable. So perhaps future results. Of the 264 enrollees, 246 or 93% qualified for data analysis, and it showed the 12-month axial elongation and SER progression of just 0.13 and minus 0.2 diopters in those treated with red light versus 0.38, almost 3 times the amount, and minus 0.79 in the control. So both the spherical equivalent also was, progress was much less, and the axial length also progress was much less. No significant adverse effects. Compliance rate was 75%, and this has been published. They also found, curiously enough, an axial length shortening of 39% in participants at 1 month, and of course much less later on. And I can't explain this, but they said we use the IOL master, which is generally accepted to be quite accurate. The hypothesis for the success is that their postulation is there is scleral hypoxia, and when you give this red light there, the blood flow increases, that ameliorates scleral hypoxia, and therefore restores scleral collagen levels, so more collagen is laid down, so the eye doesn't elongate quite that much. So of course, it's more effective in slowing down the progress of SER than the axial length. All other parameters like AC depth, corneal thickness, all that of course remain quite the same. It's approved by the Chinese equivalent of the US FDA. Only 2 patients discontinued because the light was too strong, and there were no other side effects, so it's fairly safe. According to me, these are the limitations of the study which they will have to address in broader studies. They didn't implement any masking, such as using a light treatment simulator, not giving the red light, but giving some other colored light to see. Level of compliance was not assigned randomly. They just found 75% were compliant, but it's not that you do it and you don't do it type of thing. And they've not tried other wavelengths, power intensities, exposure time, duration per session to see whether those could give better results. There was another study which did a sham. That means they give just 10% power. If the RLRL study did 100%, they gave only 10% and found that the myopia progressed more than with the 100%. So that is some evidence that we have that 10% doesn't work. Duration of the trial was just 1 year. This may not be long enough to observe full-term the myopia control effects. So we need to see whether this lasts over time. And we don't know, unlike the ATOM studies for atropine drops, we don't know what happens if you stop, whether there are any rebound effects, and whether this works in non-Chinese population as well, because it's been tried only in the children of Chinese heritage so far. So in conclusion, RLRL seems promising. I think we'll hear more of it as time goes by. We need multicentric studies to see whether it works in non-Chinese children. Longer duration of studies are required, and we need to experiment with different wavelengths, different powers and duration studies to find out which is best for all humans, not just the Chinese. Thank you so much for your attention.
Thank you, sir, for an excellent talk. Now I will invite Dr. Amar Pujari. He will be speaking Strabismus Surgical Training Wet Labs, useful tool for residents. Dr. Amar Pujari is Associate Professor at RP Center, AIMS, New Delhi. Dr. Amar.
Good morning, everyone. So I'll be talking on something practical, which we can use and we can teach it to our residents. So I do not have any financial interest with respect to this presentation. So in Strabismus, we are mainly interested in doing the muscle surgery. So to get an experience, we need to know the actual muscle anatomy, and we need to have a repeated exposure, what all the variations we are going to get with respect to muscle anatomy. Then only we can do the surgery. So if you look back, the surgical simulation of strabismus surgeries are evolving since almost like 4 decades. So what is the aim? Theoretical aspects, so many people were telling the theoretical things. Even we can read the textbooks and we can teach or we can discuss the theoretical aspects. But when it comes to exposing the muscle, suturing the muscle and passing the scleral suture, that is very critical because you need to do it repeatedly and you need to have a good thorough understanding. So for this one, I went through the literature since I'm working on this one since 2017, since almost 8 years. So I had some of the previous literatures. So after that, I tried to simulate it on a goat eye. So you can see that this is a goat eye where we can get it from the butcher shop. So initially I went there and I said that you need to retain a more amount of extraocular tissue, right? So we inspected the eyes and we got some amount of muscle. So later we said that try to retain more tissue. So in that one, we were able to see that the muscles were intact in those eyes. So whatever the eyes which had 10 to 15 millimeter of extraocular muscle which was intact, we selected those eyes. Of course, they were not perforated. They had a good tone. And we tried to fixate it on a mannequin head. So that's how you can fixate it. So that is the gauze. And you can roll it around the globe and you can fix it in the orbit. And at the free hand, you can pass a suture so that you want to simulate the normal tension. So this is simple recession and resection surgery. That is recession, this is resection surgery. So similarly, that is one possibility which I published. So later, we wanted to see whether we can simulate other complex surgical procedures which are very important in strabismus and also oblique muscle surgeries. So let's see. So this is the infraoblique muscle. So this is a globe here. So this is the lateral rectus muscle which I am simulating here. This is the inferior rectus muscle. So there is a nasal crust is there. So lacrimal crust, sorry. So this is the infraoblique muscle because we are going to take more muscles and we are going to fix it to one eye. So there is a naturally IR is there. This is the LR and I took another infraoblique. This is the lacrimal crust which I have fixated there, and this is around 9 to 10 millimeter behind the lateral rectus muscle. So this is how infraoblique muscle anatomy looks. So once you teach it to the residents and you can simulate for yourself also, see how I am hooking the muscle, I am separating it, and I am going to disinsert. So this is a free end, I am going to pass the sutures using 6-through vehicle. You can see that this is Fink's procedure, that is 6 mm inferior and 6 mm posterior to the inferior border of the lateral rectus muscle. So this is a Fink's location. So you can teach it to the resident that, of course, Fink's we are not doing it often. Parks we do this one. So Parks is nothing but 2 millimeter lateral to the inferior rectus muscle and 3 millimeter posterior. So this is a Parks level. So you can understand, you can imagine practically how this is getting recessed and also how it is getting anterior positions, right? So here you can see that this is iliac and Ankin, where this is the lateral rectus, inferior rectus lateral border. Both the sutures we are going to pass it. So we do modified DNN where one end we suture here, another end we suture here. So this is total anterior positioning. So you can see that muscle has moved from here till here. So there is a recession also. This is recession cum anti-elevation. So this is nothing but stages or anteronasal transposition. This is inferior rectus muscle. I was here. So we sutured on the anteronasal side. So we can simulate the infraoblique muscles. We can repeat it and we can practice it. So at the same time, let's see whether we can simulate other complex rectus muscle surgeries. So this is another globe. You have the muscle here. So Fardan or the posterior fixation, post-equatorial fixation of the muscle, which we do commonly. So we have the 5081 suture here. So often we suture at 14 or 16 millimeter, right? So we are going to suture it on the muscle. After that, we are going to take the muscle. You can see how the curvature or the liver arm has reduced. So effectively, this reduces the torque. That's how you can selectively weaken the muscle when it is actively acting, right? So this is another this thing eye. You can see that this is superior rectus, this is lateral and medial rectus muscle. You can transpose half the rectus muscle after splitting it. So you can do posterior fixation or without posterior fixation. So this is a full rectus transposition, superior rectus, LRMR. So it is like doing the naps with posterior fixation. So this sort of like transposition with fixation you can do because you are going to get an understanding, right? So what all the things we'll see and how the muscles are getting reoriented, how that is going to change the vector force. So this is a simple Y splitting. You have the rectus muscle, you are going to split it into 2 halves, then you are going to disinsert, right, after suturing, and you are going to recess it. So this is Nishiza's procedure or belly transposition. We have 2 rectus muscle, vertical is there. So in the respective quadrants, around 8 millimeter, right, you are going to pass the suture, and 14 millimeter from the limbus in the respective superior-temporal and superior-nasal quadrant, you are going to transpose the rectus muscle. So these are the often, almost like it covers the 95% of the strabismus surgery. So similarly, for supraoblique muscle, we do posterior tenectomy of the supraoblique muscle. So this is a superior rectus which we are simulating. So we are going to retract it. So this is supraoblique tendon. You can see that. And depending on whatever the measurements you have, 1/7 or like 2 millimeter anterior torsional fibers we are going to separate. And these are the depressor fibers. We are going to take a chunk out of it, right? So only torsional fibers are intact and the depressor fibers are gone. So this is PTSO, which we do commonly. Similarly, you can simulate the Harada Ito, where these are torsional fibers. You are going to move towards the lateral rectus muscle, right? So whenever there is a torsional inability because of supraorbital palsy, you do in Harada Ito. So this is tucking. Again, this is for to get an understanding. Tuck is done, but it is not that common. But of course, PTSO is more common. So you can fold the muscle on itself, you can pass the Weichel sutures, and you can leave it just to tighten the muscle whenever there is a congenital supraoblique tendon laxity is there. So to conclude, GOAT-I can be used to simulate various simple and complex strabismus surgeries. So in wet lab, we can use it for ourselves who are the consultants who are getting hands-on training, or you can teach to the residents, and by doing this one, we are going to get more practical experience, how to expose the muscle, how the surgical procedure actually work, rather than just saying hypothetically, right? But the limitations of these, simulations are, there's so much free space available here. You can see that, right? We need to open the conjunctiva when you are doing it on human eyes, and it's going to bleed a lot, right? So here, there's no bleeding. These are fresh eyes or dead eyes. They don't have any vessels, so that's why they are very clean procedures. But that should not give an extra liberty saying that, okay, this will be this simple. This is for understanding purpose. So we need to understand that there is so much space here. We need to have a repeated practice in a constrained space. And of course, bleeding, we need to have a hands-on training. Once we get a training here, we need to have a monitored training in the surgical OTs. And these are some of the posters we have made, which we have displayed in our National Ophthalmic Surgical Skill Center at our center, RP Center, AIMS, New Delhi. Thank you.
Thank you, Dr. Amar.
Yes.
It was nice talk about all the variety of various procedures. But have you not found that obliques are so too far away from what we see in the human
Yes,
eyes?
ma'am.
We
So,
have had this wet lab
yes,
done.
ma'am. As I said, I am suturing it 9 to 10 millimeter behind the lateral rectus insertion for infraoblique muscle. For supraoblique, definitely, because the orientation is in GOAT-I is not that practical as human eyes. Of course, it is slightly anterior. But just for understanding, we showed that one. But of course, infraoblique we can simulate. We can go posteriorly. But supraoblique, because we need to span the tendon. So if you want to find a naturally inserted muscle, which will be quite anterior in GOAT size.
Thank you, Dr. Amar. I now invite Professor Subhash Dadaya to talk about role of AS-OCT in strabismus resurgery. Dr. Subhash is Director, Professor of Ophthalmology at the Guru Nanak Eye Center, Maulana Azad Medical College in Delhi.
Very good morning to one and all. So basically, what is the role of imaging modalities in strabismus surgery? It is to understand the etiology of strabismus, good surgical planning, and it is especially important during the time when surgical details are not available, because most of our patients, they are uneducated and they don't keep the records. So in that situation, then to operate the same eye or other eye, to know the exact location of the muscle, to know the status of resected and recessed muscle and any scar tissue. Various modalities are CT, MRI, USG, UBM, and AS-OCT, and basically each has advantage and disadvantages. AS-OCT is superior in terms of non-contact, and basically the wavelength is around 310, so it generates two-dimensional images of high resolution. There is faster scanning, less scattering, there is no contact, no radiation hazard, and no need of anesthesia. So this is the machine which is being used at our center, no financial interest. So basically, we have to identify the muscle on AS-OCT. In unoperated eye, the muscle begins as a curved, thin, hypoechoic structure at the fixed distance from the angle, and this corresponds to initial tendinous part of the muscle, which then traced posteriorly corresponds to hypoechoic area that corresponds to the muscle belly. So basically, this longitudinal scan provides the lengthwise details, and the cross-sectional provides a widthwise detail, and hence combined scan is more effective and productive. And you can see the muscle in this. Then medial rectus identification. In recessed medial rectus muscle, the anterior ocular coat contour can be unremarkable, and posterior ocular coat contour can show variable thinning. In resected medial rectus muscle, the posterior ocular coat might appear thicker and irregular with variable conjunctival folds. So these are the AS-OCT imaging of the resected medial rectus muscle, which is confirmed by increased in muscle thickness at the insertion site, and this is the recessed medial rectus muscle, which is found at around 6.7 mm from the limbus. Lateral rectus identification is more easier because there is more working space and there is absence of plica semilunaris and caruncle, which shadows the visibility of the structures. And this is the ASOCT picture showing insertion of lateral rectus muscle from the limbus. So there could be errors in muscle identification. Postoperatively, the muscle image needs to be closely judged till 4 weeks because the muscle space often anomalously appear large hypotense layer which settles over a period of time with resolution of edema and conjunctival flattening. Then presence of vessels and presence of dense conjunctival folds are scarce. They interfere in identification of the muscles. So this is part of ongoing thesis where we have referred patients for the resurgery, strabismus resurgeries, and this is the preoperative and postoperative photograph of case of residual esotropia, and this is the ASOCT picture in which medial rectus was found around 7.8 mm, and when we measured with the intra-op handheld caliper, it was found at around 9 mm, and lateral rectus was on ASOCT, it was at 6.39 mm, and with caliper it was around at 7 mm. This is another case of residual exotropia with V pattern. This is the preoperative and postoperative photographs, and these are the ASOCT pictures of the medial and lateral rectus, and approximately the medial rectus was found at around 8.7, and intra-op it was found around at 9 mm, and lateral rectus was found around 13.5, and on caliper it was found at around 14 mm. This is another case of residual exotropia with V pattern. This is pre and postoperative photographs. These are the ASOCT pictures of medial rectus and lateral rectus. Another case of residual esotropia with pre and postoperative photograph. These are the ASOCT pictures of the same patients. Another case of residual exotropia. These are the preoperative and postoperative photograph of the same patients. These are the ASOCT and caliper findings, and here lateral rectus was not appreciated. This is another case of consecutive exotropia, preoperative and postoperative photograph, and on ASOCT, MR was around at 8.7 mm, and intra-op it was found at around 10 mm, and in ASOCT lateral rectus was found around at 10.85 mm. This is another case of residual exotropia. These are the pre and postoperative photographs, and these are the ASOCT findings of medial and lateral rectus. And intra-op also with the caliper, the medial rectus was and lateral rectus were found at around 6 mm from the limbus, and in ASOCT it was 6.25 and 6.47. This is another case of consecutive esotropia with preoperative and postoperative photographs, and these are ASOCT findings where medial rectus was found at around 6.05, and on intra-op it was found around 6 mm from the limbus. ASOCT lateral rectus was found around 11 mm. This is another case of consecutive esotropia with preoperative and postoperative photographs. These are the ASOCT findings of the medial and lateral rectus. This is another case of residual exotropia, pre and postoperative photographs. These are the ASOCT findings and intra-op findings of the medial and lateral rectus. This is case of left consecutive exotropia, pre and postoperative photographs. These are the ASOCT findings of the same patient on medial and lateral rectus. These are the ASOCT findings of DRS patient. And this ASOCT can also be used for measuring the vertical recti also, and here you can see the ASOCT finding in superior and inferior rectus muscle. So basically, Extraocular muscle insertion site is treated as a reference point in calculation of the amount of the surgery. Since prior strabismus surgery can alter the insertion point of muscles, a careful preoperative evaluation is mandatory, especially in patients of resurgery. And basically, this role of ASOCT, it helps to design a surgical plan by localization of the displaced extraocular muscle insertions. And I think we have done around 27, 28 patients in that thesis, and we have been able to operate only in that eye in which surgery has been done previously at other center, and surgical details were not available. So it is a useful modality for localization of displaced extraocular muscle insertions. Previously another study has been done by Savlin Kaur et al., and they have found it useful in resurgeries, and they have done only in 12 patients. And another study has been done by Dr. Ahmad Puzari et al., and they have also found it as a reliable modality. So, to conclude, this ASOCT with advanced scanning ability can be used to locate extraocular muscles locally. It is readily available for preoperative measurement of extraocular muscles, and it is useful. Thank you.
Thank you, Dr. Subhash, for highlighting use of something which is there in most institutes for other purposes, that it could be used for strabismus surgery as well. Invite Dr. Dipti Joshi to tell us about how a toxin has turned a friend, botulinum tox, in the management of strabismus. She is a pediatric ophthalmologist at the M.M. Joshi Eye Institute in Hubli, South India.
Good morning, everyone. So for the next 8 minutes, I would be taking you through the journey of botulinum toxin for us strabismologists. So it basically started as a terror, as a causing food poisoning and paralysis in 1700. And this paralysis was used by Alan Scott to induce palsy of muscles in rhesus monkey first, which was then turned into human muscles. And finally, it got an FDA approval in 1989, following which it has been used for various oculoplasty procedures and as by strabismologists. So it acts by blocking the release of acetylcholine at the neuromuscular junction. And so immediately it causes a flaccid palsy into the injected muscles and antagonist contracture or the overaction. But the effect does stay for a prolonged period of time. And how does it happen? That is because of our sensory effect and binocular effect inducing fusion, which helps in maintaining orthotropia at a later date. So the preparation, a 50 unit of botulinum toxin usually is prepared by adding a 1 ml of normal saline. So it makes a 0.1 ml which contains 5 units, that is 1 unit of your tuberculin syringe. So the most important point here is to just roll it very gently, not to shake it vigorously after reconstitution. Dosing has been a big question mark among all the strabismologists who have been using it. But if you use it solo, nearly for 40 PD, 4 to 5 units in ipsilateral, and more than that, a bilateral injection may be required. But if it's used as an adjuvant to a surgery which is already being performed, 2 to 4 units would be more than sufficient, depending on how much residual we would be anticipating post our surgery. So it's become a Brahmastra in strabismus surgery in the past 3-4 years. We have been using it in various types of esotropias, ranging from infantile esotropias to acute comitant esotropias, being used in paralytic strabismus, as well as being used in restrictive strabismus, especially in case of thyroid eye disease and few cases of nystagmus also. So let me take you through few of the cases. Like this is a case of infantile esotropia. We all know that leaving behind a small residual ET, if when both MR recession has been done, could be dangerous to the child at this age. A microtropia could negate all the effect of surgery done by us. And in those scenarios, direct injection and open sky injection, where after performing medial rectus recession, we locate the belly of the medial rectus and directly inject the botulinum toxin. The care to be taken here is it shouldn't ooze out, and after injecting, not much of meddling of the muscle has to be done, and immediately the conjunctiva has to be closed to prevent the extravasation of the botulinum toxin into the surrounding muscles and to prevent the side effects. You can see here that open open procedure still causes some amount of ptosis and some amount of exotropia to some duration of the time, but over a period of 6 to 7 weeks, the child gets restored to orthotropia. So there have been two schools of thought with respect to botulinum toxin in infantile esotropia. The first school of thought says about solo botulinum toxin, no surgery, but then solo requires multiple procedures and multiple GAs would be required. Advantages here, we can go through closed approach, so less doses and less extravasation into surrounding tissues. When used adjuvant to surgery, usually a single injection takes care of our procedure. And because it is open sky, to some extent post-operatively, we do see ptosis as well as a consecutive exotropia. But there are some clinching points which has to be taken care when we are doing botulinum toxin for infantility. For example, in this child, when we injected botulinum toxin and this child went into this consecutive XT as it was expected to us, but over a period of next 3 months, the XT didn't return back. So where did we go wrong? The amblyopia management is crucial before giving botulinum toxin into any child when we are planning with respect to surgery. If amblyopia management is not done adequately, the chances of the child going into consecutive XT fusion doesn't come back and the XT remains. An adequate amblyopia management was done and the MR which was resist was advanced, and this is the child at a later age, but it was a Herculean task. And so a learning point when we are using a botulinum toxin is an amblyopia management. Pre-injection is mandatory. In cases of large angle esotropia, as in this girl, so usually we may require 3 muscle surgery, and if we are really hesitant to go ahead with 3 muscle surgery, which sometimes at a later date can cause a consecutive exotropia, or you want to preserve the child's third muscle for a future surgery, a botulinum toxin augmented medial rectus recession. If you can see here, the left eye has a minimal ptosis, and this is over a period of next 2 months, and the child is perfectly orthotropic with the botulinum toxin augmented medial rectus recession. Botulinum toxin went into a boon after the boom of an acute comitant esotropia, which happened in the past 2 to 3 years post-COVID. So usually this works well in case of acute comitant esotropias because it is an acute esotropia. Stereopsis is good. It is mild to moderate amount of esotropia, and hence the ET, can the audio be muted please? And hence the ET is being taken care. In these scenarios, the botulinum toxin can be given as a OPD procedure too. It can be given in lying down or the sitting position. The most important point here is there shouldn't be any conjunctival bleb which is formed, and immediately the child shouldn't be rubbing his or her eyes, and a wrapping of the eyes or the protection of the eyes immediately, so that for the next 2 to 3 hours, the child doesn't rub his eyes to prevent the extravasation becomes more and more important. This is the child post-operatively. So we in North Karnataka, in the last summer, we had a boom of an epidemic of mumps viral infection, and post-mumps viral infection, in most of the children, we had a cases of acute comitant esotropia, which was a viral ET, and in some infants, we did try about only botulinum toxin in these acute esotropias, as seen here. This was a case of bilateral ET, which was seen, the unilateral left ET, which was seen in the child, and post-botulinum toxin injection, the child was orthotropic. This is another child. Both of these children are still being observed by us for the past 6 months. There has been no recurrence, but I think they do need a long-term follow-up. We need to mention the parents that any type of strabismus can recur. So none of the treatment which is being done by us is a permanent procedure. So the chances of recurrence is very high, and if that happens, a surgery is being done. So this is just an adjuvant therapy, temporary therapy. When parents are not ready for surgery, when they are not compliant with patching, at least we are taking care that the amblyopia is not happening in the child. Sixth nerve palsy is a known phenomena where we actually measure, and in the closed procedures we can give to the medial rectus muscle. Similarly, the same thing has been done in case of third nerve palsies and to treat the intractable diplopia and to prevent the contracture of the antagonist muscle. So this, before I wrap up, consecutive tackling has been another role. This is a case of a post-SO palsy where there is a left hypotropia post-SO tuck. And in this scenario, when we injected botulinum toxin into the inferior rectus muscle, there was some amount of inferior rectus underaction immediately, but later the patient turned out to be orthotropic over a period of time. So immediately, no post-operative medication is required. Follow up at 2 weeks. Please see for the early effects of the toxin, and 4 to 8 months to see the delayed effect. complications do exist like ptosis, vertical diplopia. Re-injections are required in many of these cases, and cost is one of the barriers in developing nations. But we need to select few ideal cases which are best for botulinum toxin. And as mentioned here, the acute cases, the intractable diplopia cases, cyclical deviations, which we are still doubtful about the surgery, these become some of the ideal cases. With this, we can use botulinum toxin to treat some amount of the strabismus in children too. Thank you.
Thank you, Dr. Deepti, for discussing the possibilities of botulinum toxin in the various situations of strabismus. Now I call upon Dr. Elizabeth Joseph to talk on sharp vision and straight eyes, role of LASIK in accommodative esotropia. Dr. Elizabeth Joseph is the head of the Department of Ophthalmology and Chief of Pediatric Ophthalmology and Strabismus at Little Flower Institute of Ophthalmology, Angamali, Kerala, India.
Good morning, everyone. At the outset, I would like to thank Professor Subhash Dadia for inviting me here and giving me this opportunity. I'm talking on sharp vision and straight eyes, the role of LASIK in refractive accommodative esotropia. See, accommodative esotropia can be refractive or non-refractive. In the refractive type, it is due to hypermetropia, uncorrected hypermetropia, usually starts by 2 to 3 years of age and is treated by glasses as seen in this picture. And usually, as the child grows older, the esotropia will come down because the hypermetropia also come down. But most of the time, as the child grows older, so although the esotropia comes a little down, it persists and the dependence on glasses is persistent, like in this child who has grown into adulthood. And I will present one person. This is a 22-year-old lady presented to us with hypermetropia and esotropia. And he gives history of wearing glasses for the last 18 years. And with glasses, she's orthotropic. And she doesn't want to wear the glasses. Can we offer refractive surgery? See, that person was taken for LASIK surgery. In hypermetropic LASIK, the laser ablates the paracentral circular area of the corneal tissue, unlike in myopia. In myopia, we treat the center, and in hypermetropia, we treat the paracentral area to make a central steepening. You can see the video. Yeah, you can see the video. I have applied the suction ring and Moria microkeratome. The microkeratome is being used to make the flap. And after the flap is made, the suction is released and the microkeratome and the suction ring is removed. And then an instrument like a spatula is used to lift the flap. And once the flap is lifted, the bed is irrigated well and laser is applied and the flap is repositioned. That is the flap LASIK we do. And postoperatively in that patient, she attained 6/6 vision in both eyes. And you can see the pre-op pictures. It's an esotropia corrected with glasses. This is just after LASIK. On the first day, the esotropia is gone and the refraction is corrected, and this is 1 month later picture. That means both esotropia and hypermetropia were corrected in one single sitting. And I'll present another case. This is a 13-year-old girl who gives history of hypermetropia, unilateral, and amblyopia. And the child is not using contact lenses and is not very compliant with patching. So amblyopia had become irreversible or intractable. And here we have done a transepithelial laser because the child was not cooperative for flap LASIK. You can see that straight away we are using the laser onto the epithelium, first to laser off the epithelium, and after the epithelium is lasered, we do the stromal laser. In this, there is no need of any suction ring, there is no need of any flap, less invasive procedure, and there are no flap complications. It means even if the patient rubs the eye, since it is a child, it does not produce any problem. There is no problem with rubbing, and on the table you don't have to have alcohol. Only thing, the patient may take long time to fixate, and once it is fixating, we can apply the stromal laser. And this is ideal for children or young adults. Transepithelial laser is supposed to be safer than the flap LASIK. Now let us see the postoperatively the patient had a residual esotropia which was treated by medial rectus recession. And you can see that that picture, the eyes are straight and there is no need of any glasses. So in partially accommodative esotropia, the refractive surgery will correct the accommodative portion of the partly accommodative esotropia, and after that, medial rectus recession has to be done. This is one publication. When I looked at the literature, although in 1983 we started, the laser was popularized in the 90s, but it is very popular in the treatment of myopia. And in accommodative esotropia, very seldom it is used. So this procedure can be popularized. That is the purpose of this presentation. See, another article showing the effectiveness of refractive surgery in accommodative esotropia in children with special needs, and children and adolescents also with special needs. Clinical outcome of 108 cases was published in the Investigative Ophthalmology 2013, and they have shown good results. Again, this is another article from JAPOS 2004. The LASIK is effective in hyperopic eyes. See, when we discuss about hyperopia, unlike myopia, in hyperopia, all the parameters like the axial length, dioptric power, etc., get stabilized earlier than myopia. So you don't have to wait up to 18 years of age. This is again another literature search showing that both LASIK and PRK are effective in the long-term reduction of accommodative esotropia. Sometimes accommodative esotropia goes into decompensation. In that case, even if you correct the refractive error, you may have to do a strabismus surgery. How young can you do refractive surgery? Actually, FDA approval is only after 18 years. That is the FDA approval. But many perform refractive surgery in children. And the younger stage is still not established. The difficulty is to get a good fixation even after a general anesthesia. And when you do LASIK, issues like eye rubbing is there when you do in a younger child. But it is worth the trouble in anisometropic amblyopia. Latest preferred practice pattern in American Academy of Ophthalmology, I had looked in 2024, they have recommended refractive surgery in accommodative esotropia, especially if it is associated with anisometropia and amblyopia. And special concerns in hyperopic laser, the regression. Regression is more common in hyperopia. Corneal regression caused by the progressive change in the shape of the cornea after LASIK intervention, and flattening of the central cornea may cause decrease in the corneal power. And if there is a latent hypermetropia, it may become manifest. So these are two things which we have to remember when you do a hyperopic LASIK. That means later on there may be some refractive problems. And to conclude, refractive surgery in refractive accommodative esotropia is effective in the correction of refractive error and strabismus at one shot. This is well received by patients. Long-term results are good, stable and safe. Main indications are adults with fully or partially accommodative esotropia and older children who are not compliant to wearing glasses or contact lens, and children with special needs. Thank you very much.
Thank you, ma'am, for an excellent talk. Now I invite Dr. Sweta Chaurasia. She will be speaking on full tendon modified Nishida's procedure in large complex strabismus. Dr. Sweta is working as associate professor at PGI Chandigarh, India.
Thank you, sir. I would like to thank Dr. Dadia for having me here. To begin with, transposition procedures are often useful in improving ductions past midline and at the same time correcting large angle primary position deviation in large angle concomitant strabismus. But recessing the tight antagonist with full tendon transposition can bear the risk of anterior segment ischemia if done in the same sitting and even when spaced with time. So partial tendon transposition and modified Nishida are the safer and popular alternatives, but efficacy remains low. Because the vector forces used in modified Nishida no-split nototomy transposition procedure consist of only 1/3 of the muscle width with mean correction of only 30 prism diopters. So we described a no-split nototomy full tendon modified Nishida procedure in a rare case of bilateral medial rectus aplasia in which we use the full muscle width, and we got a good alignment in the primary position along with the correction of adduction. So let's see the varied case examples of large angle strabismus managed with this procedure. First, a patient of monoocular elevation deficit who presented, he had squint surgery done outside. Right eye inferior rectus was recessed for 4.5 mm way back. On motor examination, he had a hypotropia of around 30 degrees in primary position and SR under action of -4. Ptosis workup revealed a severe ptosis with poor Bell's and Marcus jaw winking. So full tendon modified Nishida was done in the right eye and the left eye RNR was done. And you can see that there was primary position alignment was achieved along with improvement in supraduction. So this is the surgical procedure. Traction sutures were passed and limbal incisions were given temporally. The superior rectus was hooked and check ligaments were dissected. The muscle was isolated. 8 mm was marked on the muscle and non-observable 6-0 dacron was used and the muscles were secured. Now 14 mm was marked along the superior border of the lateral rectus and the same needles were passed to the marked site and the same needles were then passed to the superior rectus and the muscle was mobilized. Similarly, the inferior rectus, the procedure was done, 8 mm was marked and muscle was, then 14 mm was marked at the inferior border of the lateral rectus and again the sutures were passed through the sclera and through the muscle. So the modification in our technique was that the full width method was used as well as we transposed along the border of the lateral rectus, unlike modified Nishida where the sutures were passed through the sclera between in the midway between the superior rectus and the lateral rectus. So there were 7 patients who were operated and there were 3 patients who had IR recession done prior and 3 done in the same sitting. So mean preoperative hypotropia improved from 65 to 4 prism diopter at the end of 6 months. Mean pre-op supraduction improved from -4 to -1.36. So mean correction achieved by this procedure alone without IR recession was 52 prism diopters. And Bell's improved post-operatively, following which ptosis surgery was done in all the patients. These are some of the other patients showing improvement in primary position and as well as improvement in supraduction. So coming to the sixth nerve palsy, this patient presented with post-traumatic sixth nerve palsy in the right eye. You could see there was a large esotropia in the primary position of around 50 prism diopters with abduction limitation of around -4, -5 because the eye was not coming to midline. Then force duction test was moderately tight for medial rectus and force generation test, there was no tug. So this was the post-operative picture after the procedure. You could see the improvement in the primary position alignment as well as improvement in abduction. Then the patient did improve with the binocular free field of around 10 to 15 degree and along with the improvement in binocularity. This is the patient after MR recession preoperatively showing residual esotropia which was corrected after this procedure in showing improvement in abduction. So there were 8 patients which were operated and all of them underwent this procedure along with the MR recession and mean pre-op esotropia improved from 65 to around 2 prism diopters at the end of the 6 months. Mean pre-op abduction deficit improved from -4.29 to -1.36 and mean correction achieved by this procedure was 41.75 prism diopters. There were 2 patients of esotropic DRS which were operated of 45 and 40 prism diopters. Mean abduction was improved from -4 to -1 in each of the patients and they underwent this procedure along with the MR recession and correction achieved was 30 and 25 each. Then there were 2 patients of exotropic DRS, and mean abduction was -5 in each patient. Both of them underwent LR periosteal and full tendon modified Nishida. This is the patient after LR periosteal fixation showing deficit abduction. So the full tendon modified Nishida was done after the LR periosteal, and mean correction achieved by this procedure was 25 and 30 base out respectively. Then there were 3 patients of lost muscle, and mean pre-op exotropia improved from 71 prism diopter to 21 prism diopters post-operatively, and adduction deficit improved from -4.67 to -0.27 prism diopters, and mean correction achieved by this procedure was around 52 prism diopters. So this is the boxer whisker chart showing the correction achieved by each of the procedures, and you could see the overall mean correction was around 44 prism diopters. The vertical group improved around 53, and the horizontal the procedure improved around 40 prism diopters. The mean correction achieved by in the restrictive squint was smaller, but the overall p-value was statistically significant, but applying Bonferroni correction, the multiple comparison, the adjusted p-value was not statistically significant. If we compare the results with the augmented full VRT, and we found a similar results. Even in cases of restrictive strabismus, our results matched with the study with Velez et al. So we didn't had any anterior segment ischemia in any of our patients, which we did with the ICGA. To conclude, this full tendon modified Nishida is a safe and effective procedure in correcting large angle incomitant strabismus and improving ductions when done with or without ipsilateral antagonist recession. Without tenotomy, this technique displaces the full thickness pulleys of the bellies and hence the muscle center in the direction of the transposed side, which is close to the border of the paralyzed muscle, resulting in greater tonic ducting force. Thank you.
Thank you, Dr. Shweta. And we now have Dr. Leela Mohan to tell us about large angle exotropia, recess resect with muscle transplantation. Dr. Leela is a senior consultant and head of the Department of Pediatric Ophthalmology and Strabismus in Comtrust Eye Hospital, Calicut, India.
Good morning. Let me thank Saupo for giving me this opportunity. So, recess resection with muscle transplantation in large angle exotropia. Large angle exotropia, the definition is not very precise. We may consider more than 60 prisms as a large angle. Large angle intermittent exotropia often become constant over time and bears a great psychosocial impact on the patient. Often there is a dominance of one eye in these cases. Sensory exotropia with a large angle is also not uncommon. Sensory exotropia, often this single stage surgery may not be enough in these cases, and exotropia of more than 55 prisms often need more than 2 horizontal muscle surgery involving both eyes, which may not be acceptable to the patient, especially in sensory exotropia. So, coming to the surgical options, best option for large angle exotropia is debatable, and most of the surgical procedures give undercorrection or lateral incomitance is not uncommon. Maximal or supramaximal recession, that is 2 muscle surgery with augmentations with either Botox injections to the recess muscle or central tenectomy to enhance the effect of recession, produce palpebral fissure changes or lateral incomitance. 3 or 4 muscle surgery, that is bilateral lateral rectus recession with one or both medial rectus resection, is often chosen in large angles. And Riza et al. Evaluated the dose response of 3 muscle surgery in large angles up to 80 prisms and found it to be 2.5 to 3 prisms per millimeter. So even with these suggested tables, undercorrections are very common in these cases. And in recess resection with the transplantation, the segment of resected muscle is used to lengthen the lateral rectus, which prevents muscle from creeping forward, and the actual insertion remains behind the equator, so ocular movements are not affected. So this is a resection of the medial rectus, 6 millimeters. Two sutures are placed at the resection and at the where disinserted, and after clamping you take the muscle. Usually we get only about 5 millimeters even after 6 millimeter resection because the muscle shrinks to some extent. And in exotropia, the medial rectus is less, the lengthening is less available, but in large angle esotropia, you get a larger amount of resected lateral rectus. So still about 3.5 to 4 millimeter enhancement is obtained in these cases. You resuture after taking the resected muscle, you insert it to the recessed lateral rectus. Should I fast forward? This was done under topical anesthesia, so we have placed a cotton button over the cornea. So this is the resected muscle which is sutured to the distal end of the lateral rectus, and after suturing it to the distal end of the lateral rectus, the muscle is inserted to where you want the recessed muscle to be, in this case 10 millimeters behind the insertion of the lateral rectus. So it is sutured, and so I think I will. Yeah, that is the lengthening obtained, and would like to fast forward it. So that is about 10 millimeter behind the insertion of lateral rectus. We are suturing the muscle. So how does it work? Up to 90 prisms of exotropia can be fully corrected with this technique, and the transplanted muscle undergoes fibrosis by the end of 3 to 4 weeks. Elasticity of the muscle is lost, but the autologous nature has the advantage of tissue spacer and maintain the tensile strength. Roger Hayat in 1973 has shown in animal studies that the tissue, though it loses elasticity of the muscle, attaches to the sclera by about 3 weeks and is viable. And he did the first transplant in humans as well. So this autologous tissue can be used for an extension of the recessed muscle. In the 90s, it was mainly used for resurgeries by Diamond et al. And later, many surgeons, including Amitava, Jitani, and many others, have shown it to be useful in primary surgery in large angle strabismus. So these are some of the cases. We have done recess resection with muscle transplantation and under local topical anesthesia. And a correction ranging from 85 to 95 prisms was obtained in these cases. And it was maintained for more than 6 months. And no abduction limitation was seen after 3 months. There was some amount of limitation of -1 immediate post-op, but no abduction limitation was seen after 3 months. So often patients are not willing to get both eyes operated at the same time, and in long-standing exotropia, the chance of second surgery are very high. And recess resection with transplantation gives us maximum correction, and a second surgery may not be necessary. And topical anesthesia in this age group especially gives an edge for the prolonged time for surgery, in which case the peribulbar block may wear off also. So unilateral maximal recess resection with transplantation is a good option in large angle exotropia and can be successfully done under topical anesthesia too. Thank you.
Thank you, ma'am, for nice talk. We were given the mandate to finish the session at 9:15, and we have finished it at 9:15. And I will request all the speakers to come for a photograph.
We are about to commence the ceremonial inauguration of the Annual Ophthalmological Congress 2024 of the College of Ophthalmologists of Sri Lanka and Association of Vitreoretina Specialists of Sri Lanka. Please remain seated.